Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the School of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I'd like to welcome Dr. Chris Snyder from Tidal Health, Peninsula Regional. New name, we're getting used to that.
Yeah, I love it.
And you are the Chief Quality Officer there, and you're also Chief of the COVID response team.
Yep, that's correct.
For the hospital. And of course, you have a lot of experience and information to share, although it does seem things are ever changing. So we want to get the update on where we are on certain topics with regards to COVID-19.
Great. Okay.
So let's start with the virus itself. Do we know anything more about this virus and how it's transmitted?
Yeah, we're learning every day. I think there's a lot of studies being done to try to determine the phases of the virus when before and after illness, so we can identify it sooner and get folks to treatment. One of the challenges here is it's very elusive. In the beginning of all this, it was very aggressive and actually fatal in multiple cases. So it was a scary virus to play with in the beginning. A lot of us didn't know what we were doing with it because it's a new transmission of this virus. So it's something that really, as a healthcare provider, was first day of med school again back in March. So because we were really learning how to identify this, and the rapid nature of it taking people's lives was apparent right away. So because of that, we had to figure out ways to identify it. We've come a long way in 6 months. We're much more comfortable with it. We've rebuilt our hospital, our community, the country, you might say, and we've done some amazing things. But we're at a point now where we're starting to need more and more identification, earlier identification and awareness. Right now, there's still a lot of I call it shotgunning, where we're testing throughout the country, everybody. That's not the way I typically practice medicine. So most healthcare providers focus more on symptom-based testing than on just testing. So, and at this point, we have to figure out where the happy medium is in that. And we'll talk a little bit more about testing, but I think there's a lot of opportunity here to identify better ways to recognize this bug in the community and take care of it before you get too sick.
So I know you wanted to talk about some theories, or there may be a genetic predisposition involved, as there is now with many illnesses and diseases.
Yeah, well, genetics, fortunately, is in our tool bag, so we're excited to have that. They're running some really interesting genetic studies looking at this virus and how it mutates when it gets into your body. And a lot of people don't realize you consume the virus and then it attaches to cells and it expands itself within your body, and it mutates based on the response of your body. So little viruses are smart little critters. They have a way to survive. They're just like you and me. When it's cold out, we put a jacket on. Well, when they get attacked by a T helper cell, they put coverage on and change. That way the T helper cell can't identify them. So chemically, there's a lot of things going on in the body that we're trying to identify. There's the most recent theory is called the bradykinin theory. And the best way I can describe that is when you're in a family of 6, only one child has the peanut allergy and has anaphylaxis. So when the child eats peanuts, they stop breathing. They have a massive immune response. That immune response shuts down their airway, stops them from breathing, and creates a very unsafe environment. Now, the other 5 people can eat peanuts. They all have the same genetic makeup. So what's different about that one person? We really don't understand that. It's kind of similar with COVID. COVID really creates a acute or a very rapid onset of an inflammatory response that causes the events that occur in a COVID patient, including the lungs, the brain, the kidney, every organ's at risk. Early on when we were seeing this, it was a catastrophic event that occurred, and unfortunately it was killing the elderly and the folks who had underlying disease. But it's a very interesting process to see how that rapid response is triggered and what's different about that immune system in those folks who couldn't tolerate it to the ones now who are just getting it and not really that sick.
Or having no symptoms at all, which
Absolutely.
is really challenging.
Yeah.
I know one of the articles I read talked about how it settles in the nose in particular, and that's why people need to cover their nose with the mask especially. And that's one of the reasons the sense of smell and taste seem to be one of the major symptoms that can occur.
Yeah, the higher the viral load in the nose is really the higher the spreading capability too. So it's important we understand that. Now, unfortunately, right now our testing doesn't show us the response from the immune system, so we can't see the antibody response and define when it's high or when it's low, what that impact is. So there's some challenges with that. They're called titers, and those titers are really necessary for us to tailor treatment in the future, hopefully, and also to identify your stage of the disease. That's super important for clinicians to use.
Well, following up on that, aren't some people getting an antibody test, but that's different than the titers that you're talking about?
Sure, highly discouraged. Don't know what you're going to get out of that. The antibody test really doesn't have any significance in the evidence yet, so you can order it. I don't know what it means.
Well, I guess some people say you can test positive with antibodies, but then they can go away.
Yeah, we don't even know what that means. So a positive antibody test, I can't even comment on it. There's no evidence around whether it's convalescent, which means it's past the infection, or whether it's active infection.
Active infection.
So if you have high antibodies, what does it mean? I don't know. The science isn't there yet, and that takes years to develop. So as we are testing and identifying, groups like NIH, Mayo, they're doing their best to quickly do that. But unfortunately, when people get sick, you have to measure, and then remeasure your measure in order to get to that identified scientific, and it has to be done in a blinded study.
Well, staying on the testing, I know you wanted to talk about the PCR test because it is the gold standard, and that's the one with the nasal swab. It's quite uncomfortable, but, talk about that.
It is. So at Tidal Health, I mean, we have 5 different PCR tests. Those are genetic tests that actually some of them are rapid at 1 hour and some of them not so rapid at 4.5 hours. And we're utilizing those because they have the best sensitivity, although not great. They're still better than what most of those other tests. As you mentioned earlier, there's a salivary test that they're saying it could be utilized. I really don't know what that's about yet until we actually get laboratory science saying when you have an elevated level, it means this. The interpretation of these tests really require an understanding of what you're doing with it. And it's really important. An asymptomatic patient could have dead virus in their nose that they were exposed 3-4 months ago to. And that virus makes that test turn positive. Doesn't mean you're sick. Doesn't mean you're contagious, but you have a positive test. So what does that mean? So again, that's where the titers would come in to be helpful. If I tested you for an antigen and it was positive with the nasal test, then I would look at your serology to be able to see if it was indeed an active test or a convalescent test.
Meaning taking a blood sample.
Correct, yeah.
Okay.
So those are all the things that go together when you're trying to label folks. Right now, the best test I have is your symptoms.
And what are they, just to refresh our memories?
Perfect, I love it. So, the old flu symptoms. So flu symptoms are probably the onset, fever, low-grade temp. It can be 100, 100.1. Not a big temperature with this, but it's a persistent temperature. Usually lasts 2 to 3 days in most young people who get over the virus in 3 to 5 days. So, but a low-grade temp, sore throat, runny nose, congestion, and typical flu, muscle aches and joint aches. That's probably one of the big ones. The most interesting one is the loss of taste and smell. And that to me is pathognomonic for this bug. So if you have that, you probably do have COVID if you have a fever and other symptoms. It's one of those things that it really does kind of nail it for us. I'll be honest, and that's the way I practice medicine. I listen to you, I evaluate you, and I treat you based on that. I don't ever treat tests, I treat people. So by me getting that history from you, it is super duper important that it helps me focus on my diagnostics, whether it is flu or whether it's not. We also see some diarrhea in the convalescent phase of this, so usually not early on. They usually get it on day 2 or 3, which is common with viruses because that's how they leave your body.
I know, you hear headaches, it's like the symptoms are all over the place.
They are, and again, everybody's got COVID right now until proven otherwise, so it's really difficult to assess sometimes. So
it's challenging, all of it. It's very challenging because it's new. It's something,
we're getting better at it.
Haven't had a pandemic in 100 years, they say.
Not don't want to do it again either.
Yeah, I think for our lifetime, this is it,
Yeah, I hope so.
hopefully. Now, what about risk factors? They're evolving. Of course, some of the common sense ones we've heard are, if you have a lung condition, underlying emphysema or hypertension.
Yeah, so kind of the syndrome X type of thing. So people who have diabetes, hypertension, and obesity are definitely at a higher population. Again, genetically, we're not sure why, but those are the folks that got super sick in the beginning, and folks who are at risk for it also. There could be some ethnicity to this. We do see that Black, Hispanic populations definitely had a higher mortality, and we saw that in our population with migrant workers. We're getting sick very quickly. So there's a lot of risk factors there that we utilize to assess. And then exposure, obviously, which is one of the key elements. And I think the definition of being exposed is being misinterpreted by a lot of folks who really don't understand the disease, but it's really less than 6 feet for more than 15 minutes unprotected. And again, it's a virus, so you're going to have to exchange saliva, body fluids to really get infected with this bug if you're not sick.
And obviously coughing and sneezing and laughing. I mean, you hear just about anything that propels the aerosol droplets.
Right, so those droplets are key, and that's why we're doing all the precautions we are, which we'll definitely highlight here.
And one of the things that's come up more recently kind of made sense to me all along, because obviously if you smoke cigarettes, that puts your lungs at a disadvantage, but now vaping they're talking about, because you can share devices, spread it that way, and the effects of the vaping in the lung tissue.
Yeah, heart failure, chronic pulmonary disease, any of those things, asthma, definitely puts you at a little higher risk just because it's a virus, and viruses like RSV, CMV, all the children viruses, and then the adult viruses like flu, H-flu, and a bunch of the other ones are focused on the respiratory system. So again, you inhale it, but antigenically you get a response, immune response that affects your lungs and causes these problems. So I think that's really important. The vaping, the smoking, all precipitates inflammation in the lungs. So whenever you're pretty much taking in a vapor that's not air, you're going to create, so whether it's perfume, anything that would trigger an asthmatic attack can also set you up for those things. So it's super important you take care of your lungs with this bug.
Okay, let's move on to treatment. I know you have firsthand experience with this when it first hit the shore, and Tidal Health, of course, back then it was Peninsula Regional, had to respond. So what are some of the key treatments that are used now for persons hospitalized with COVID?
Yeah, when you come in the hospital, we use the conventional steroids, which again, early on was utilized in very, very sick people. So it really got a negative tone towards steroids early on. But they've come back around. I think about 6 weeks into it, we'd actually been using them since day one because, first of all, the treatments for this bug are symptomatic only. They don't they don't fix COVID. COVID is one of those things, there is no cure for COVID, to be honest with you. You can't kill it with an antibacterial. It's not going to go away other than washing your hands. Once it's in your cellular system, it has to run its course. We don't have any way to reduce the viral load of it and stop it from replicating. So that being said, you have to treat the symptoms and supportive care. Steroids help reduce inflammation, so they help in the lung. And we've had some really good results with early studies that came out of actually Vanderbilt and Tulane. Their pulmonologist and our pulmonologist were talking. So we started very early on using steroids and had some really good results. The second one that was kind of unusual, a lot of people with COVID came in with blood clots. So we saw thick blood for some reason. And again, it's probably immune related. But because of that, putting folks on blood thinners early on in the acute phase was really important. And we actually had some patients, if they're super, super sick, we'll actually send them home on blood thinners for 2 to 4 weeks after hospitalization. And we found that to be very effective. And I think the studies are supporting what we're doing there too. And we started that very early on because of the amount of lung blood clots we saw coming through the door with COVID patients. It was pretty alarming, actually. And then the other two are more investigational. Remdesivir is a common antiviral that's very common in the utilization in the COVID population. the studies are really not strong other than the over 65 population, where it's being used very early in the treatment phases. So using that on somebody at home may be reasonable. The guidelines are saying if you're over 65 and have underlying risk factors, then you would probably be a good candidate for the 5-day therapy or remdesivir. We are utilizing it some in the hospital, but not as much as plasma, convalescent plasma.
Yeah, talk about that. That's an interesting.
And it's interesting. That's basically a blood product. So we take a infected patient, we draw their blood off and spin their blood down and just use the plasma part of it. And then we will utilize that and transfuse it into an actively ill patient. By doing that, we're actually giving them the antibodies from that blood, from that COVID previous patient. So, so the important thing about that is you have to have the right amount of antibodies in that plasma. The studies have shown that the best folks to get that plasma donation would be those sickest folks. So we're utilizing it in our sicker population in the hospital. And we're actually in a study with Mayo Clinic. We have 7 or 8 physicians who are running that study at our hospital. And we're sending candidates for that study there. So we're following a very strict guideline on the distribution, screening, and utilization of that drug. And that'll be really interesting. I think we've sent close to 40 patients now through that process, which is great. So the benefit of that, though, is the antibody titer, and that's the important part of that. People don't realize if you don't get a good dose of antibodies from that donor, it really doesn't work well, and that's what the studies are showing. We get our plasma right now from blood bank, local blood banks, so we don't test for the antibodies before we give the plasma to patients, which is common because there's not enough blood banks. The big centers that have their own blood banks in-house are running antibody testing, and they're actually doing research to help us, guide us a little bit on which plasma types to use based on the blood donor. There was a big theory about blood type putting you at risk early
type
on.
A.
Yeah, so not really there anymore. It's not a blood type issue. So I just thought that might.
Well, that's good to know because I'm type A. I was like, wow, okay.
Yeah, no, you're good.
Well, I think taking care of yourself helps a lot too.
It does.
You know, good immune system and avoiding some of those problematic behaviors.
Absolutely.
And little luck, you said, genetics, little luck.
Yeah, and the vaping thing you talked about earlier, I think sharing the vape was also a problem, especially in the younger population. And you know, again, you're anytime you're sharing saliva, you're gonna, whether it's a drink or utensils or dishes, you're gonna have a higher risk of transmission.
Exactly. All right, last but not least, let's talk about the vaccine. Everyone's just thinking, you know, we need a vaccine, and there's many of them in development, but we know they have to be tested properly, and it won't be an automatic rollout where everybody will get the vaccine. No. So where are we on all that?
Yeah, we got time. So vaccines require titers to measure the response from the vaccine. One of the limitations I think they're having is having an accurate titer. So there's a lot of studies, a lot of research going on around it. I am far from a vaccine expert, but I'm also skeptical to think that it's going to show up at the end of this year with 3 months left. We're not even into human trials, and human trials take years. They really do. The FDA is very specific now. I think what they're doing genetically with the development of these antiviral vaccines is spectacular. I think it's amazing how quickly they're generating the animal trials, getting through those with a very rapid, safe fashion, just to prove safety first. But the human trials are going to take longer, absolutely. And we want them to take longer because we want it to be correct when we give it. We don't want to be giving it, and there's a lot of factors. The complexity of vaccine medicine is you know, again, in the hands of IDSA, which is the Infectious Disease Society of America, and they are doing what they need to do to develop these things.
Sure. I mean, I'm hoping when vaccines, or there's probably going to be more than one, you know, they will be deemed safe and effective to some degree. Although I think I read they were thinking you're going to need at least 2 shots of it.
Yeah, and that's what the whole titer thing is, so we can measure the effectiveness of it, because again, we want to make sure it works if we're going to give it. And much like the flu vaccine, you get 1 a year. I don't know if this is going to be a once a year, once in a lifetime, similar to what we do with Hep B. Hepatitis B vaccines, you get 2, and you get 1 in a booster. But again, the complexity of all that with all the different genetic types we have is what's going to be very challenging.
And of course, briefly mentioned herd immunity, which means you're going to have some people that may be immune to it from having it, and then we have to get everybody else, or a good number of people, up to speed, percent of the population, so to speak.
Yeah, and there was, I think the path, if everybody looks at the way the surges occurred, you bring up herd immunity, which is a theory around, immune response in a community. And again, it's one of those things that's not truly proven, but there is an effect or an impact. And I do believe the surge we saw early on affected folks who genetically probably couldn't respond well to the virus. They may have had a missing protein or whatever it is in their system, plus diabetes on top of it or any other underlying disease. And those things really set people up for failure, and unfortunately the rapid nature of that disease. Now that that's gone away, it's kind of almost cleared the population a bit. Now everybody's getting about the same level of disease. They're sick, but they're not real sick, especially when they're hospitalized. And in the community, we have a ton of asymptomatic, not so sick people too. So
well, I guess that's the one good thing. We saw that peak where people were just dying at a rapid rate, and now we've kind of plateaued out and not overburdening hospitals and ICUs, which was a major concern, I imagine, on your end.
Oh yeah, it was pretty scary for the staff, doctors, nurses. We had no idea what we were looking at. The interesting thing too is that, if you're seeing the numbers out there, I think it was 97% of people do fine with this virus. They have really minimal illness. Out of the 3% who get sick, only probably about 10 to 15% actually die from it. Very low numbers, which is good. But on the other hand, we don't know if everybody's been exposed yet or not, because we're still closed up a lot and wearing protective items. So the mask is super important. Going forward, we have to have a mask. A mask helps aerosolization, but more importantly, it keeps your hands out of your mouth and your nose and your eyes. And it reminds us all that we have to keep distance. So the mask is a bulletin board for safety and for hygiene. And probably the most important thing is wash those little paws. Our hands are by far the #1 transmission of any bug. And at a hospital, that's what we're taught to do. So I was excited when I came to your bathroom here, use it, not personal, but there was a picture up there and saying, wash 20 seconds, sing your happy birthday, do your thing, and scrub, scrub, scrub. You can't wash your hands enough.
And in the absence of not being able to wash your hand, using a hand sanitizer
Absolutely.
with 60% alcohol or more. So I know I keep hand sanitizer bottles all over the place.
Yeah, we all are. It's good.
Yeah.
It's a good thing.
It is.
If anything good came out of this, we're all cleaner. And we really are taking the time to
more
do those things.
cognizant of this
Absolutely.
kind of thing.
Yeah, most definitely.
And I know you also wanted to emphasize that I know a lot of younger people say, well, I don't, even if I get it, it's no big deal. But we still don't know a lot of the long-term effects. We know some, that may happen in some people, but I think it's not an innocuous thing. If you get this infection, you could have some long-term effects. I know you wanted to touch on that briefly.
Yeah, it is. We're seeing people come back into the hospital with chronic lung, cardiac issues, kidney issues, dialysis, folks with some depression in the community. We're not sure why all that's happening, other than the virus causes a chemical injury to the lung or to the kidney or whatever. And again, it's it's creating some new types of illnesses associated with COVID that we're probably, it's going to take us years to probably identify all the potential effects this has on, besides economically, physically, what it's going to do to some folks. I think the majority of people do fine with COVID. These people coming back are our sickest patients. So they're the ones that were on ventilators for 2 weeks, and they're going to have problems anyways. But now it's just when they do come back in, they're having some chronic illness. The story's still out on that one. We're just going to have to wait and see and keep identifying them.
Well, it does seem like we're not seeing it as much in the older adult population, partly because we are isolating people that are in nursing homes and retirement assisted living facilities and so forth. But I know we also wanted to bring up, in addition to wearing a mask, washing your hands, keeping that 6 feet distance, it is a smart idea for people to get the flu vaccine, particularly this fall, correct?
Yeah, absolutely. We're giving all the employees the vaccine already. Keep up with your vaccine. Again, I'm hoping we see less flu this year because of the good hand hygiene and the mask wearing and the isolation and all those protective measures should help with flu also, because it's a similar transmission. But you can't stop with that. You know, we know the flu vaccine has a huge impact on morbidity and mortality in our country, so it's important.
Vaccines are good. Now
They
they
are
say
good.
vaccines don't save lives, the vaccinations save lives, so
Yes.
people have to get them.
Yeah, take the time, go get it. We'll be running our vaccine lines, I'm sure, like we always do with all the new Tidal Health organizations, and I'm looking forward to kind of seeing what happens with all this, but we'll just keep our fingers crossed. Unfortunately, tomorrow's unknown, so we'll see.
It's ever evolving, as I've been
is.
saying.
It is.
So anyway, that might help, because they're calling it could be a twindemic, you know,
Yeah.
the flu and
Yeah, I've heard
COVID.
that
So
too.
at least take care of the one thing you can take care of until we get a
Absolutely.
vaccine on the other.
Most definitely.
Well, thank you so much, Chris, for all the
Oh, sure.
very useful information, helpful for our viewers to learn more about COVID and what's the latest information, because it's changing.
It does. It'll be different tomorrow.
Well, hopefully not too different, or hopefully some news on a vaccine.
Yes. Yeah.
Even though it's not going to be an overnight cure.
No, it's not.
But thanks again, I
Sure, thank
appreciate
you.
it. And thank you for joining us for this edition of Focus on Health here on PAC 14.